And joining us now, Dr. Michael Rachlis. He is Associate Professor at the University of Toronto and a health policy analyst, and a guy I've known for about 30 years, talking healthcare in this province and in this country. So you're the guy we want right now to start talking about misconceptions. We've discussed Canadian misconceptions about the U.S. healthcare system. Let's flip that around. To the extent that they ever think of our system, what misconceptions do you think they have in the States about what we do here?
I've spent a lot of time in the United States. My wife is American by birth, and her family lives in Louisiana, and we're there several times a year. And I've also had opportunities to meet with folks in Washington over the years. And I think that the two big misconceptions people in the United States have about our system is, number one, that you can't choose your doctor, that it's a sort of like not a communist, but more than communist. It's really a Stalinist kind of system that you get a doctor, and if you complain, you're sort of shot kind of thing. Secondly, that Canadians supposedly have a universal plan, but they wait for everything and they can't get anything, and if they do, it's like a 1950s Band-Aid, everything's out of date. So I think those are the two big misconceptions Americans have about our system.
And they still think we're responsible for 9/11, that the hijackers, and yet you say it 100 times that it's not the case. Why do they still think that when it's not the case?
I think that there's a whole number of reasons why the United States is less aware of us than we are of them. But and clearly that people in Louisiana are a lot less well informed than people in Buffalo, for example. Right. But in general, I think it's because the U.S. doesn't have to know much about Canada. And to be fair, even in our own example in Ontario, I find, since I travel across the country, that people in Toronto are often quite ignorant what goes on in the rest of the country. So it may just be from being at the imperial center.
Fair point.
But I think that another thing in the United States is that there's been a very large lobby since 1948, although it's now funded differently, to misinform Americans about the Canadian healthcare system and make it more difficult for them to adopt it.
Well, all right, let's pick up on that. What aspects of our healthcare system do you think could serve as a model for what Americans may be about to do? Because, of course, with Barack Obama in power now, he's talked about radical transformation of what they do down there.
Yes, and it's also interesting to look back that Canada and the U.S. had essentially the same healthcare systems until 1947, when Tommy Douglas's government in Saskatchewan brought in their hospital insurance program. Then we had federal hospital insurance in the 50s, and then national medical insurance, which all provinces joined by 1971. So, but during up until the 1950s, we spent the same on healthcare as the U.S. We had the same healthcare system basically as the U.S., and our infant mortality and life expectancy were about the same. So now, what did we do in Canada? Well, we haven't actually done a lot. We don't have a government-run system, as my American friends sometimes tend to assume. We have a government finance system, but in Ontario, most physicians are in private practice, and most hospitals are private, although not-for-profit organizations, and are certainly not low at campaigning against the government on issues like money if they feel they're not being treated well. So that we have a system in Canada where we have public insurance for hospital and physician services, patchy public insurance for things like drugs. Everybody in Ontario over 65 is covered, but I'm not covered, and I'm not complaining, but I pay thousands of dollars a year for medications. I'm a self-employed person, and so is my wife, and we have good incomes, and I'm not complaining.
But you're a prof at U of T. How can you not be covered there? I mean, most people who work in this province are covered.
I'm part-time at U of T, and I put in, probably over 100 hours this year. But it's all volunteer work, and then I'm self-employed as a consultant on the side to earn my living. So that we only have patchy coverage. We've got coverage for physicians and hospital services, and up until recently, we have not had much government transformation of the system. We basically, in Ontario in particular, had 150 independent hospitals, 20,000 or so independent physicians, and they're funded through public insurance. But the government really, up until the last 10 to 20 years, didn't really try to shape the system. And now, of course, in Ontario, we've got local health integration networks, or LHINs, and we've got family health teams, and many family physicians are in different models. But the transformation is still sort of slow. So how have we done from having that public insurance? We've done tremendously, because in the U.S. they're spending, as I'm sure Antonia has told your guests about all sorts of spending in the U.S. is much higher than in Canada. But in Canada, we actually get more services than Americans do. So they're spending about 6% more of GDP, 16% versus 10%. They're spending almost twice as much per capita, and about a third of all their spending goes to administrative expenses on health insurance because they don't have a single payer system for hospitals and doctors.
Okay, but tell me this. If you're insured in the United States, so you're not one of those, whatever, 40 to 50 million people who don't have health insurance, if you are insured, do you get better care down there than we, all of whom are insured, up here?
That's a good question. About somewhere between 15 and 20% of Americans have no coverage whatsoever. And then another 20 to 40 million, maybe 10% or more of the population has a policy, but they don't realize that their policy won't cover them until they get a serious illness. And so as an example, my wife's first cousin used to be the assistant manager of the Louisiana State University bookstore in Baton Rouge in Louisiana. 50,000 student university. She had a very responsible job. Her husband was a full tenured professor of history at LSU. And they had health insurance problems because their family doctor, who they loved, changed insurance plans. And because he hated their insurance plan, he wouldn't cover people on Bob and Carolyn's insurance plan. So they had to change insurance plans to keep the same family doctor. And when they did that, for 1 year, they weren't covered for pre-existing conditions, which is routine in the US. Bob had high blood pressure. If he'd had a heart attack or a stroke during that year, their family would have been bankrupt. So even people who think they have coverage aren't necessarily covered in the United States. And Christopher Reeves, the actor who played Superman, who became a quadriplegic in a horse accident, there's a fine print on most US health insurance contracts that says a maximum lifetime cap. His was $3 million. He burned through that quickly. And if it weren't for his friends Robin Williams and others, he would have been destitute. So that even if you think you have insurance in the US, you may not be covered.
You may not.
If you have insurance and it does cover things, then you can usually get as much as you get in Canada, sometimes a little more, sometimes a little less, and you'll get it faster.
Well, let me put these numbers out. You just referred to these numbers, and we have talked about them earlier in the program, but let's remind everybody here. Total health care costs. These are numbers as of 2005. Canada, you're right, almost 10%. The United States, more than 15%. As you look at obviously what the Americans spend, much more than we do as a percentage of their economy on health care, do we get a better bang for the buck for our 10% than they do for their 15 plus?
I'd say overall we do. And the reason is that about half of that extra spending in their case is the extra administrative charges due to their private insurance system. 1,000 insurance companies selling health insurance in the US. Each of them needs computer systems, actuaries, sales and marketing people. Tremendously drives up the price of their overhead, right down to the hospital level, where the Massachusetts General Hospital in Boston has more people working in their billings department than OHIP has at their head office in Kingston. My wife, I don't practice medicine now, but my wife was in private practice for a while with 3 of her friends in family practice, and they had to pay one of their clerical staff maybe an hour a month to do all their billings and reconciliations with OHIP. A family doctor in the US probably has to pay somebody 20 hours a week to do the same job there. So the extra costs of overhead go throughout their system, and it's about a third of all that Americans spend on healthcare that goes to pushing paper around their mainly private system. The second reason why the US spends more than we do is they pay higher prices. So that subspecialist doctors in the US make a lot more than subspecialist doctors here. Heart surgeons in the US will make...
What does a subspecialist make there versus here?
Well, that ear, nose, and throat doctors, eye doctors can easily be making $2 million, let's say, in the US. And in Ontario, they'll still be making a good living, but typically around 400,000 or 500,000. On the other hand, studies have shown that for family doctors, particularly if they're working in poor areas of town, might make more in Canada than the US. Specialized nurses like nurse practitioners will make more in the US, where many are making 150,000 or more. Typically in Ontario, they'll be making between 80 and 100, if that. And, but on the other hand, ward nurses, and particularly orderlies, non-professional staff in hospital, people in kitchens, et cetera, will make more than their US counterparts, which is partly due to the fact that in Canada, our rich aren't as rich, but our poor aren't as poor as in the US. But the US has been, and of course they're paying higher prices for drugs. An MRI scan in the States is going to cost more than here. Anybody who's had to get care in the States knows how much it costs to put it on your credit card if you're there. So that between paying higher prices and a lot more money for administrative overhead, In Canada, we get more days in hospital, more days in nursing homes. We have more visits to family doctors every year. We take more prescription drugs per capita. Our drugs are a lot cheaper. So you can go on and on that we are getting less heart surgery per capita than the US. We are getting fewer MRI scans, although studies in Ontario and other places question whether we need even as many as we're getting in this province. And we get some services slower than they do in the U.S., which is an interesting issue to come back to.
We are going to come back to that one, but I want to show you two charts. Check that monitor up over my shoulder right there. I want to show you two more charts. Here's total healthcare cost, once again, 2005, most recent year for which figures are available. Percentage of GDP, and I'm going to compare Canada here to 3 European countries. You see we're up nudging around 10%. The French are over 11%, the Germans are nudging towards 11%, the Swiss are almost at 11.5%. But I want to flip those numbers now to make them age adjusted. And if you age adjust these numbers, Canada's over 11%, or at 11%, the French are down, the Germans are down, the Swiss are down. So is it possible that our healthcare system is actually more expensive relative to these other countries than we think it is when you adjust for factors around age?
That's a very good question. And of course, this analysis comes from the Fraser Institute. It's never been published anywhere else. It's never been published in a peer-reviewed journal.
Is it false, though?
And it's completely fallacious analysis. And the reason is that there is no relationship internationally. There is a relationship in a country. The older you are, the sicker you're likely to be. But when you're trying to compare internationally, there is no relationship between expenditures on healthcare and the age of the population. And so that this is sort of an ecological fallacy. By looking inside a population and finding something, you then assume that a comparison between that population and another one. And this is a fallacy that junior master's students will make, and then their thesis supervisors will crack down on them, and they'll never get to even compete for a PhD if they continue to make that.
Why is that misleading?
And the reason it's misleading is, for example, the oldest country in the world is Japan. And which country of the wealthy countries of the world has the lowest healthcare expenditures?
Japan.
Japan. Which country in the world, which of the wealthy countries, which is the youngest country? It's the United States. Which country of the wealthy countries spends the most on healthcare?
United States.
The United States. So there's no relationship. There's no and this analysis, which it takes about 30, it takes about 5 seconds to say.
What's the motive for that analysis?
And Mr. Ismail and Dr. Brian Day has also used this analysis. This is only used by people who use Fraser Institute material,
what end?
And they use this because then it fallaciously makes the Canadian healthcare system look more expensive. But it's a completely fallacious analysis, and in fact, our spending is just what you showed, that we're spending about 10% of GDP on healthcare. It's around what many other countries, wealthy countries that Canada compares itself to, spend, like Sweden and France and Germany. It's a little bit less than some, like France and Germany. The extra money that Germany is spending on healthcare, if we spend in Canada as a share of GDP, would be roughly $15 billion. And we could use $15 billion for, amongst other things, a complete national child care program. So it's not, we are doing better than they are in terms of cost, but we're in the same ballpark. And then there's one country that's completely out of the ballpark, which is the United States, which is, depending on the figures you look at this year for 2009, it's no doubt going to be about 17% of GDP.
Okay.
And Canada is going to be about 11%.
We got about 5 minutes left here, and I want to talk accessibility with you. Critics of our system say, yes, everyone has access, and it's pretty fair access, and the rich, under most circumstances, can't buy their way to the front of the line, but it is access to the same level of what they would view as unfortunately mediocre care. Is that fair to say?
It's fair to say that we wait longer for care than people in most other countries, and there's no question that I certainly agree with people who otherwise might be critics of Medicare. We wait too long for specialist appointments, elective surgery, family doctor's appointments.
The point is, are we waiting too long for care that is not that good at the end of the day anyway?
Oh, and the care at the end of the day is comparable to other countries. Now, you can always find, if you go from hospital to hospital in Ontario, you'll find some excellent things in some hospitals and some very bad things in those same hospitals. It's typically a departmental thing. Now, more and more, I'd say the governors of Ontario's healthcare system are moving towards more standardized excellence, but we're still a long ways away. So that if you look at any country's healthcare system, you'll find some things they do well, some things they do poorly. And if you've got 30 million people in Canada, there are some people on any given day who are getting bad healthcare. There's absolutely no question about that. But on the other hand, comparing our results for heart attack care, car accidents, other care with the United States, we do as well or better. You know, typically, at the end of the day, our survival is the same from whatever you look at. It's just that in the U.S., they've done, you know, like 3 times as much things to you in hospital. But our outcomes are quite good. And international studies comparing cancer survival, by and large, we do as good as the U.S. and other countries.
Let me follow up on that, because Antonia Maioni in the last segment, we put the numbers up there that show that they have per capita in the United States more doctors, more nurses, more MRI machines, more CT scanners. Does all of that mean they have more and better health care than us?
It's certainly not overall. And again, you can go to some places in the U.S. that are fantastic, like the Mayo Clinic. But the University Health Network in Toronto or the Trillium Health Center, I mean, these are noted around the world to be centers of true excellence. But I think that the big, so there's little question that overall we are doing just about as well as the U.S. in terms of getting the care that we need, and we're spending 6% less of GDP, and the analysis is half of that difference is administrative costs, half is due to higher prices. But I think that going beyond that, it's really important to note that the problems we do have in our system, particularly waits and delays, have nothing to do with the fact it's a government-run system. It has everything to do with the fact that we brought in what Dr. David Naylor, president of the University of Toronto now, titled his book 20 years ago, Public Practice, Private Payment. And in fact, we have a system that's publicly financed, but it's still, in Ontario, mainly privately administered by private not-for-profit hospitals and private practice physicians. When, as we've seen Dr. Alan Hudson, who's the head of the Ontario Wait Times program, when you get the government actively starting to manage things, then you see that wait times for cataract surgery, hip and knee replacement have plunged from like 12 to 14
So it's
months
about management.
down to 4 to 8 weeks.
in a-
It's better management. That's what we need, and it's nothing wrong with the fact that we built our system on equity.
You know what? I've known you for so long, and you still never let me get in there. You're a filibuster with the best of them. I got a minute left here, according to Tina. Give me one good idea. If it's a case of management, not private versus public, give me one good idea that would get the wait times down, because I know that's a big issue.
Advanced access, a method of reducing wait times for family doctor's appointments. There's a number of clinics doing this in Ontario, about 1/3 of Saskatchewan, same-day appointments for family doctors with the number of doctors and nurses we've got now. Hamilton has integrated the practices of 100 family doctors with 17 psychiatrists and 80 social workers, and they have increased access for mental health by 1,100% while reducing the pressure on psychiatry specialty clinics by 70%. And downtown Toronto, you phone the Kensington Eye Center or you phone the Holland Orthopedic Center, and within 2 months and sometimes within 4 to 6 weeks, you will have your cataracts done or your hip or knee replaced. All of these things could be done across the province, across the country, if we had the political will and the management to do it.
Which we don't, you think?
It's slow. Dr. Alan Hudson deserves a lot of credit, and well, some other people in Ontario, for making some of these big changes that are happening here. But it's way too slow. We could have same-day access for primary health care in Ontario, within 1 week access for specialists, and within 2-month access for all elective surgery, with more or less the resources we're spending now if they were better organized. So let's get on with it.
More on all of this in your book, Prescription for Excellence, How Innovation is Saving Canada's Healthcare System. Michael Rachlis, good to see you again. Thanks for coming into TVO tonight.